Good day to all. This is Erica Rosemont, Acting Deputy Director for the Division of Clinical Innovation. I will be presenting an overview of the UM1 FOA and providing technical assistance on applying to this opportunity. The content of this presentation has been developed by myself, Stacia Fleischer, Director for the Office of Grants Management, Victor Henriquez, Scientific Review Officer, as well as other NCAT staff. During the presentation, we encourage you to send your questions to the CTSA FOA questions at mail.nih.gov, what I will refer to as the CTSA FOA mailbox. At the end of the presentation, we will answer questions that we have received. Questions that are institutionally specific will not be answered during the webinar. Before we begin, we do encourage applicants to read the entire funding opportunity, and if they have questions, to send them to the FOA mailbox. Questions and answers are posted on the website on this page and will be updated periodically. This presentation will not be an exhaustive one, but will cover highlights and areas of emphasis, and we will go over some questions that we've received to date. This is the list of the overview. So the purpose of this funding opportunity announcement invites applications for this Clinical and Translational Science Award Program hubs that will be part of a national collaborative consortium focused on bringing more treatments to more patients more quickly through advancing clinical and translational science. And we're proposing to, the purpose is to focus the applications on one, developing, demonstrating, and disseminating scientific and operational innovations that improve the efficiency and effectiveness of clinical translation, from identification to first-in-human studies to medical practice implementation to community health dissemination. 2, promoting partnerships and collaborations to facilitate and accelerate translational research projects locally, regionally, and nationally. 3, creating, providing, and disseminating innovative research programs and partnerships across institutions and communities to address health disparities and deliver the benefits of translational science to all. 4, creating and implementing scientific and operational innovations that increase the quality, safety, efficiency, effectiveness, and informativeness of clinical research. 5, providing a national resource for the rapid response to urgent public health needs. And 6, creating, providing, and disseminating clinical and translational science training for clinical research professionals of all disciplines on the research team. We would like to call your attention to the project period for this grant is up to 7 years, not 5 years as in previous CTSA funding opportunity announcements. The first thing we wanted to highlight is the need for a cover letter for the application. The cover letter helps staff connect all companion applications and review them for eligibility. This includes the required K-12 clinical scientist institutional career development application and any optional companion funding opportunities for training, research education, and high-impact specialized innovation programs. The letter must describe any of these companion applications, and each application submitted concurrently with the UM1 should submit an identical listing of the companion applications. There has been some confusion regarding whether our existing CTSA grantees can submit a renewal. The answer is no. Although the FOA indicates that new renewal and resubmissions are allowed, it also says as allowed. For clarity, if a renewal was to be allowed, the FOA would have indicated from which other FOA a renewal could have been submitted. The FOA does not say this, and to be clear, all applications submitted to this FOA are considered new. Another note for our current CTSAs is that you must have less than 16 months of support remaining on the day of submission to be eligible to apply. And finally, it is critical that applications follow the research, our instructions, except where instructed to do otherwise in the FOA or in the notice, or in any notices. This is a change from the last CTSA FOA, where the instructions were M, multi-component instructions. Also, we suggest to regularly review the FOA section where there are related notices, as applicants must adhere to those notices when applying. We want to call your attention that we will be reviewing applications for non-responsiveness. Applications that are not responsive will not be reviewed. They are applications that do not answer yes to the involvement of human subjects. We've often had confusion during the review about whether the application should or should not have this information. And let me be clear, it is expected that grantees will be conducting research with human subjects at some point in the lifetime of the grant, either in their pilot projects or the Clinical and Translational Science Research Program. Applications in which PIs do not commit at least 2 months effort each. Note that all PIs must commit at least 2 months and preferably 3 to 6 months effort to the award. Applications that lack the required K-12 and applications that lack a specific plan describing the partnership between the UM1, the required K-12, and any optional components. And I will describe this in the next slide. The UM1 is part of a collaborative set of companion applications. As stated previously, a K-12 is required to be submitted concurrently with the UM1. All other companion FOAs are optional. The applicant may choose to submit these companion applications concurrently or wait for the UM1 to be awarded. If the UM1 is unsuccessful, then the U and the K must be resubmitted together, even if the K gets a good score. If the UM1 is successful and the K is not, then the K may be submitted without the UM1 once the UM1 is awarded. A comment about the number of applications that can be submitted concurrently or after the award of the UM1. Only a single application may be submitted for the T32 pre-doc, T32 postdoc, and or R25 research education FOAs. 2 applications may be submitted for the RC2 FOA. Only a single award for the T pre-doc, T postdoc, and R25 will be awarded for every single UM1. Up to 2 awards will be provided for the RC2 for every single UM1. A brief reminder that each application must provide a specific plan describing the partnership between the UM1, the required K-12, and any optional components. Specifically, in the UM1, there is a required coordination and integration plan that is found in Section 4 of the application. The plan must describe the overarching goals of each component and the coordination, integration, synergy, and mutual reinforcement of resources between the components and include a description of the roles of any shared partners and/or collaborators. The plan is limited to 3 pages. If you read the required and companion FOAs, you will see similar requirements for those applications as well. This is a visual of the UM1 FOA broken into sections in the purple and elements of the research strategy in dark blue. Note that per application, there is 1 budget, and the budget justification is broken down by element and module, and 1 set of criterion scores and 1 overall impact score. You will not get individual scores for each element. The first thing to highlight are the page limits. So the specific aims is 1 page. There's only 1 specific aims for the whole application. The research strategy must consist of element A, which is the overview, of 6 pages, element B, the strategic management, of 12 pages, element C, training and outreach, of 12 pages, element D, clinical and translational science resources and pilots, of 18 pages, and element E, clinical and translational science research program, of 6 pages. So one of the questions we've received is about the CTS research program. The page limits for this section is 6, no matter how many projects are proposed. Applicants must provide at least 1 clinical and translational science research project. There is a typo in the FOA under the page limits. The CTS research project should be program. A note about the module leaders. Each CTSA Program Hub application must include the 5 elements and the associated modules. Element A, the overview, doesn't have any leaders. Element B, the strategic management, has a strategic management module leader and the application PI. The contact PI must be designated as the strategic management module leader. Element B will also include a hub liaison team, scientific lead, and an operations lead. For element C, training and outreach, module C1, the workforce development for clinical research staff professionals, will have a module leader, and module C2, the community and stakeholder engagement research, will have a module leader. Element D, clinical and translational science resources and pilots, will have 3 modules and 3 leaders, including resources and services, clinical and translational science pilot, and health informatics. And then for element E, the clinical and translational science research program will have a research program leader. An individual may not have more than 1 leader role, and co-leaders are allowed. We have received a question about, can you have more than 2 leaders for an element? And the answer is no, but you can have co-leaders. Moving now to the award budget. The first thing is that an application is submitted by a single institution, plus the option of 1 or more partnering institutions or 1 or more collaborating institutions. We note that a partnering institution must be effectively integrated into the proposed activities of the Hub and are necessary for attaining the Hub's strategic goals and research priorities. This will be described by applicants in the attachment number 3 for the information on Hub partners and collaborators. Note that any institution may only be a partner with a single CTSA Hub application. However, any institution may collaborate with as many hubs as they want. A collaborator also has a significant role in the Hub and may be included in more than 1 CTSA application. The key difference between a partner and a collaborator from the award budget perspective is that only the partnering institution's NIH clinical research funding is used in calculating how much a CTSA may request for their budget. This FOA supports 4 sizes of Hub applications, A, C, T, and G, with the maximum direct cost listed in the right column. So how does an applicant determine how much they can request and what tier they're in? There are 2 tables that are used to determine the tier an applicant is in. The first table, Table A, provides the 5-year average of the most current NIH direct cost funding for the applicant institution. Recall that there may be only a single applicant institution. The second table, Table B, provides the 5-year average of the NIH total cost in clinical research of any partners. Showing that here, an applicant would add the NIH direct cost funding of the primary applicant institution plus that of the NIH total cost funding in clinical research for any partners. This will add up to one of the tiers, A, C, T, or G, and that is what an applicant may request. If there are any discrepancies in Table A or Table B, please notify NCATS immediately. A note about any applicants that choose to partner with HBCUs, TCCUs, AANAPISISs, and or Alaska Native and Native Hawaiian serving institutions. They may choose to use Table A, the NIH direct cost funding, or Table B, the NIH total cost funding, whichever is higher. More information about these institutions may be found on the website listed here. A couple of things to emphasize here. Applicants must use the fiscal year 16 through 20 funding tables for application due dates of January 26th, May 13th, and September 16th. This means that all applicants submitted in a particular fiscal year will use the same tables. We will be updating the tables and releasing them on our website on an annual basis. Applicants are strongly encouraged to verify that they have used the correct tables and verify their funding tier prior to submission. This ensures that there will be no issues on the back end in making an award. Applicants should submit their calculations to the CTSA FOA mailbox, and once NCATS has verified the calculation is correct, they may note this in the budget section of the application. For more information, please see the website listed at the bottom of the page. Moving on to definitions we have used in the FOA. There are a number of definitions in the FOA I wanted to highlight here. So the first one is translation. This is defined by NCATS as the process of turning observations in the lab, clinic, and community into interventions that improve the health of individuals and communities, from diagnostics, preventions, and treatments to medical procedures and behavioral changes. Translational research is defined by NCATS as the endeavor to traverse a particular step of the translational process for a particular target or disease. Whereas translational science is the field of investigation focused on understanding the scientific and operational principles underlying each step of the translational process. The next definition has caused some confusion previously, and those are the terms of diversity, underrepresented, and underserved. So diverse or diversity includes but is not limited to race, ethnicity, socioeconomic status, background, gender, and mental or physical ability. And we direct you to see NIH's notice of interest in diversity here. Underrepresented, for the purposes of this FOA, is used in the context of the workforce, being represented in numbers that are disproportionately low. Underrepresentation in extramural programs is tied to national representation ratios, not institutional demographic data. Again, we refer you to the notice. And underserved, for the purposes of this FOA, is used in the context of health disparities related to population-based health. A population is defined by the Minority Health and Health Disparities Research and Education Act of 2000 as a health disparity or underserved population if there is a significant disparity in the overall rate of disease, incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to the health status of the general population. The CTSA Program Summary Data Guide was employed to save space in the narrative and help reviewers find information. These attachments include a description of the institution and the Hub organization, the Hub senior leadership, information on Hub partners and collaborators that I alluded to previously, resources and facilities, clinical trial experience, clinical and translational science track record, and the coordination and integration plan that I also alluded to earlier. More information can be found on the link below. We've received a few questions about the other attachments that I'll address here. The first question is, where should all the resources available at the institution, partners, and collaborating institutions be described? There's actually two places in the application where these may be described. The first is in the other attachments in the resources and facilities attachment. This will provide a listing of specific resources that are anticipated to be used during the performance period of the UM1. And the second is the facilities and other resources attachment in the R230 Project Performance Site Location form. Another question that has been received is, should the clinical and translational science track record accomplishments be focused on the Hub activities or on the applicant institution's track record? For the answer to this, we refer applicants to the review criteria described here so they can be responsive to the FOA. The next question is, For clinical trial experience, when is the 6-month window for reporting? The answer is the 6-month window is up to and prior to the application. Applicants should indicate the time frame they are reporting. We refer to the relevant text in the FOA. A note to clarify that we were alerted that the text in the FOA and the text on the website with the attachment templates were not harmonized, and they are now. Moving on to element B, strategic management. We want to highlight from this element that applicants must include salary for 1, quality assurance, quality control position to perform quality reviews of CTSA-related submissions to NCATS, submissions to the ERA Human Subject System, and management of the overall process. We have seen a huge impact in the quality of submissions from supporting a dedicated position, and we want to continue this. So we've received a couple of questions relevant to element B. So the first question, how should hubs plan for interacting with the consortium-wide activities of the Center for Leading Innovation and Collaboration, CTSA National Center for Data to Health, and the Trial Innovation Network? So the current consortium-wide activities are supported through cooperative agreements. As grantees evolve or change, we did not directly name the current grantees in the FOA. However, applicants should describe their commitment to interfacing with current and potentially new national collaborative activities. The next question, how does the Hub Liaison Team differ from the CTSA Hub leadership with elements B, C, D, and E? The answer is the CTSA Hub senior leadership and the Hub Liaison Team individuals may be completely separate or may overlap. We note that an individual may have more than one leader role and co-leaders are allowed, and that the intent of the FOA is not to have more than 2 leaders per element. We've had this question. The next question, how do applicants support local and regional initiatives? One of the CTSA program goals is to promote partnerships and collaborations to facilitate and accelerate translational research projects locally, regionally, and nationally. Applicants are provided the flexibility within the UM1 mechanism and a single budget to balance the emphasis within the Hub's activities and are encouraged to leverage their strengths to drive innovation that would have impact on the Hub stakeholders and communities. This allows the Hubs to showcase their unique strengths and capabilities and are expected to strengthen the consortium as a whole and advance clinical and translational science. We note that new collaborative activities will be supported through the funding opportunity listed in this slide, resources for rapid demonstration and dissemination, and furthermore, applicants should plan to describe their Hub Liaison Team in their application. The relevant text from the FOA is provided here. Moving on to element C, training and outreach. As we have received questions about whether the UM1 may accommodate costs for the K, T, or R25 companion FOAs, we want to emphasize the following, that personnel support related to the required and optional companion training and education activities may be included in the UM1 budget if there is a role on the UM1 for integration endeavors and the costs are not duplicative. Applicant institutions should include a statement providing assurance that the activities and costs are not duplicative with the UM1 activities. Failure to provide an assurance statement will result in the removal of potential duplicative costs prior to award. Moving on to element D, clinical and translational resources and pilots, we provide the following enhanced guidance for the clinical and translational science pilot module. Applicants must include costs for the review, tracking, management, and overall administration of the module, as well as the pilot projects that may be included, a minimum of 4 and a maximum of 8 pilot projects per year, budgets between $25,000 and $50,000 direct costs per pilot, and the pilot project period cannot exceed 12 months. So what's new about this, in addition to this guidance, what's new is cost sharing is not allowed with the pilots. Pilot projects must be fully supported with NIH funds awarded through this funding announcement. The review process, resources, and expertise developed through this module may be utilized for the review of other projects not funded through this application. However, NIH assumes no responsibility for those projects and should not receive any reports related to those projects. We'll get into additional guidance about cost sharing shortly. And a final note about pilots, please do not include any individual pilot projects in the applications. These are submitted to NCATS for prior approval after the award is made. More information can be found on our web page listed here. We've received a couple of questions relevant to element D. So the first question, can the application include a description of specific individual pilots? As I just said, no. This section should include only information about the establishment and management of this clinical and translational science pilot module and should not include any proposed pilots. And here we provide relevant text from the FOA. As indicated earlier in this presentation, we direct applicants to the definitions in the FOA for translational science and translational research. As there's been a lot of questions about what's the difference between a translational science project and a translational research project. We note that translational research pilot projects are not allowed. We direct applicants to read the examples in the FOA listed here that may be supported, and we've provided a number of resources on our website listed at the bottom of this slide for background reading on what translational science is. Moving on to notables under element E, Clinical and Translational Science Research Program. The program direct costs for the CTS research program must not exceed $500,000 per year in direct costs. Each CTS research project may not be less than $125,000 per year in direct costs for a suggested period of 2 to 3 years. We've had some questions about the cost of the projects per year, and here we clarify that an applicant can spend not less than $125,000 per year in direct costs. Multiple projects may be undertaken concurrently. Each hub must request at least one project in this application, and subsequent projects will require prior approval if the project includes research with human subjects, vertebrate animals, and/or foreign components. And as a reminder, element E can only have 6 pages in total, and at least one project must be described. We've received a couple of questions relevant to element E. Again, we want to highlight that element E can only have 6 pages, irrespective of how many projects an application describes. An application must describe at least one project. Any subsequent projects will require prior approval if conducting research with humans, vertebrate animals, and/or foreign components. The next question is, how many research program leaders can there be? If there are 5 projects, should there be 5 research program leaders? Any element may have co-leaders, 2 leaders. It's not required that a project PI be the leader of the clinical and translational science research program, but additional project leaders may be named following the grant award. The next question, should applicants include a description of individual projects that will be pursued in the CTS research program? Again, the answer is yes. Each hub must request at least one project in the application. A follow-on question, how do applicants fill the 7 years with research projects? Recall that multiple projects may be undertaken concurrently, or the applicant may decide to conduct another project later in the grant. Noting that if the project is conducting research with human subjects, vertebrate animals, or has a foreign component, it will need prior approval by NCATS. Final question for element E. Can applicants collaborate with other hubs? There is no restrictions to collaborating with other hubs on element E CTS projects. Moving on to cost sharing, we want to call your attention that this FOA does not require cost sharing, but that any applicant identifying voluntary committed cost share in the budget sections of the application will be bound to the cost share commitment for the entire approved project period. However, voluntary committed cost share will not be accepted and will not be considered in the review score of the following categories: key personnel, the resource and services module, the CTS pilot module, or the CTS research program element. Voluntary committed cost share for other items identified after peer review will be considered. However, any alteration in cost share commitments for the specified categories prior to award will deem the application ineligible for award. Future award consideration would require submission of a revised application. We want to remind you of the following definitions as it relates to cost share. Direct funding is full and/or partial funding allocated directly to the project from the federal funds awarded. Voluntary committed cost share is in accordance with uniform guidance. Voluntary committed cost share is cost sharing pledged by the grantee institution on a voluntary basis that is quantified in either the proposal budget or narrative and becomes a binding requirement of the award. Voluntary uncommitted cost share is any effort or resource contributed to a sponsored award that was not included in either the proposal budget or narrative or committed to the sponsor prior to the award. Questions relevant to cost sharing. We have been asked, why is cost share not considered in the review score for the described items? Answer is that we are following the federal regulation under Uniform Guidance Section 75.306 on voluntary committed cost share as detailed and further described here. Per the federal regulation, NIH cannot consider voluntary committed cost share as a factor during the merit review of applications in which cost sharing is not required. There has been a rise in voluntary committed cost share proposed in CTSA hub applications. As such, NCATS must ensure compliance with the federal regulation. NCATS has an obligation to ensure that voluntary committed cost share is not considered as a factor of merit review, since cost share is neither expected nor required for this program. Consistent with the federal regulation, NCATS has provided explicit guidance in the Notice of Funding Opportunity as to how voluntary committed cost share will be considered. Applicants considering proposing voluntary committed cost share in a grant application should work directly with their office's sponsored programs and/or authorized organization representative to understand their institutional policies and procedures for voluntary committed cost share prior to submitting their applications. The next question is, what does the term monetary support mean in the following definition? Institutional commitment, access to and utilization of substantial and well-integrated resources, does not include monetary support, which is neither required nor recommended for applications submitted to this FOA. The term monetary support means voluntary committed cost share, and we reference the text in the FOA. We will go over some of the review criteria for the UM1 now. The application will be evaluated as an integrated effort. We have received questions about whether individual elements or modules will receive independent scores. The answer is no. Reviewers will provide an overall impact score for the application. In addition to the standard review criteria, there is review criteria that is specific to this FOA. And so if an applicant is wondering how to be responsive to a certain aspect of the FOA, We encourage them to look at the review criteria that will provide them with the information about how reviewers will be directed to assess the particular aspect. Here we want to highlight that in addition to available funds and merit, we do look at the relevance of the proposed project to programmatic priorities, including but not limited to geographic distribution of the hubs, partners, and collaborators that could enhance and/or accelerate the CTSA's capacity to advance the CTSA program goals and to address the burden of conditions that affect rural, minority, and other underserved populations. In addition, policies consistent with goals for resource, data sharing, and sharing of software. The UM1 mechanism is a cooperative agreement, and as such, there will be substantial NIH programmatic involvement with the recipients during the performance of activities. We note that the NCATS CTSA project collaborator acts as the NIH program official and is responsible for the normal stewardship of the award. A couple of highlights for the PI's primary responsibility is working with the project collaborator and meeting with them on a regular basis and providing data to NCATS to help us measure the impact of the CTSA program. A couple of highlights for the NIH project collaborator's responsibility is helping facilitate interactions, coordinate access to resources, and assist the hubs in responding to emerging areas of high priority or national impact, including public health emergencies. Finally, this table is in the FOA and it provides when the application is due, when it goes to review, and council, and the earliest start date. And these are the scientific, peer review, and financial contacts for any questions related to the FOA. We can all be reached through the FOA mailbox listed here. Periodic updates of the web content for the application information will occur using questions submitted to the FOA mailbox. The website is listed here. And now we'll address other questions received during the webinar. Thank you for your attention.